So good afternoon, everyone. My name is Emily Haynes. I'm the Director of Public Health Initiatives with the Partnership for Maternal and Child Health of Northern New Jersey. Welcome to this afternoon's Essex Metro Immunization Coalition meeting. I am going to turn it over to Dr. Joseph Schwab, our EMIC chair, and Dr. Schwab's going to open the meeting. Thank you for joining us today.
Okay, thanks, Emily, and thank you all for joining us today. It's really a pleasure to see you all again and hopefully hear from you. Today, we're going to focus on HPV, so we're looking forward to that. We've got a couple of presentations. First of all, as is traditional, we'll give an opportunity for everyone, especially new members or people joining us for the first time, to introduce yourselves and let us know where you're from. And in the meantime, I think we sent the minutes around prior to the meeting. So if anyone has any corrections or additions to the minutes, you can put those in the chat, or also your agreement with them. So we'll take a vote in the chat as well to make sure that we can enter those into the record. So again, welcome, and if anyone would like to start by way of introductions.
I can start, Dr. Schwab. Hi, everybody. My name is Iris Novas Cooney. I am the Community Health Education Manager for Horizon NJ Health government programs. And I've been an EMIC member for how long, Emily? I lost count at this point. How many years? 8, maybe? I don't even know. Sounds about right.
It sounds about right.
I'm looking forward to hearing from you, Dr. Schwab, on today's presentation.
Thanks, welcome.
I can go next. This is, so let me put my camera on. My name is Maureen Kuhn. I'm with the American Cancer Society. And with me today are two more ACS colleagues, Anna Paisley, who's waving, and Michael Sesserman, who is also on and with ACS as well. And possibly Michelle today. I haven't seen her on yet, but she'll be coming. Thanks.
I'm going to see a few introductions in the chat as well. Shirley Johnson's here from SPAN. Welcome back. Haven't seen you in a while. Glad to see you on. Rachel from Montclair Health Department. Manaz from the dental school here at Rutgers. Zachary Elric from the Adolescent and Adult Immunization coordinator at the New Jersey Department of Health. So welcome to all of you. Anyone else?
Dr. Schwab, I can go next.
Yes.
Hi, this is Monisha Prakash. I'm a pharmacist by trade, and I work for AstraZeneca Medical Affairs, supporting FluMist specifically and our vaccine immune therapies portfolio. I happened to meet Emily at the New Jersey AAP meeting just last week. So just wanted to join, say hello, and see how I can take advantage of opportunities to help improve immunization rates across New Jersey.
Great,
Thank you for having me.
Welcome.
I can jump in. This is Gene Malin. I'm the account executive for Merck Vaccines for the state of New Jersey, and a pleasure to be on board. And kind of the same, I'm looking forward to see how we can support to increase overall vaccination rates.
Great, thank you. Welcome.
Hey everyone, it's Leanne Lowenthal. I work with the partnership. I'm the NJIAS trainer and recruiter.
Welcome. Thanks.
I guess I can go. Hello.
Yeah, go ahead, Peter.
Okay, I'm Peter Wenger. I'm a pediatric infectious disease physician at old medical school comrade and work partner with Joe for many, many years at both New Jersey Medical School, then known as UMD&J, and then the University Hospital. I've been a member of EMIC from the beginning. I haven't been at many meetings as of late since I've been not working in town, but now I've started back working part-time at Newark Beth Israel. So it's good to be back and see all my old friends like Joe and Emily.
Yeah. Welcome, Peter. Welcome back to Newark. Thanks. Thanks for joining.
Good afternoon. I'm a trainer and recruiter for NGIS by way of the Partnership for Maternal and Child Health. And happy Wednesday.
Thank you.
Hey
That's
guys,
good. No, I was going to say it's almost Father's Day and Juneteenth. So happy Father's Day and happy Juneteenth.
Thank you.
Amy Barbado, Merck Vaccines as well. Happy to see some familiar faces.
Thanks for joining. Let's see a few more names in the chat. Melanie Dios, coordinator of the Essex Passaic Wellness Coalition here at Rutgers. Katie Stewart, public health educator from Morris Somerset Regional Chronic Disease Coalition. And Melissa Hart, who's a program manager of the Immunization Initiative at the Partnership. Jasmine Anderson, also with Partnership Immunization Education Specialist. Anyone else before we move on?
Good afternoon, everyone. I'm Yoreni Simon. I'm the Public Health Program Coordinator under Immunizations at the Partnership. Thanks.
Great. Thanks for joining.
Hi, good afternoon, everyone. This is Jenny Sudhakaran, Population Assessment Coordinator from the Vaccine Preventable Disease Program. Glad to be here today. Thank you.
Hi, everyone. Lovely Randall from New Jersey Department of Health. I'm the program specialist with the VPDP program.
Great. Thanks for joining.
Hello, everyone. My name is Jennifer Smith. I'm the health educator for the Vaccine Preventable Disease Program.
Welcome.
I'm Jessica Mindo. I'm the Union County Chronic Disease Coalition Coordinator, and I'm also the Union County MRC Coordinator for Union County.
Great. Thanks for being here. Okay, so welcome to everyone. The other order of business before we move into the talks is the minutes. So if you do get a chance to review those, I think it's easiest just to put in your chat, whether you vote to approve them or if you have any corrections. So that can be ongoing as we go through the meeting. So like I mentioned before, today we're going to be concentrating on HPV vaccine. And so I have a presentation that I'm going to give, and then Yoreni is going to join us with some local efforts related to HPV vaccines. I hope it's informative. For many of us, it'll be a refresher, but I think it's an important thing for us to concentrate on, especially given the decreases in HPV coverage that we've noticed, especially through NJIS here in New Jersey, to kind of recommit to our efforts to this important vaccination and the health of our young people and young adults. I'm going to share my screen and go right into the presentation. Okay, so can you see the slides now?
Yep.
Yeah, great, thanks.
Yes.
Okay, so we're going to, this is going to be an update on HPV vaccine. I have no conflicts of interest to report. And I'd just like to acknowledge the information that I've obtained and the experience I've had with working with the CDC, the AAP, both the National and New Jersey chapter, the National Immunization Partnership, and most importantly with EMIC. I've learned a lot over the years, and I've really come to appreciate the importance of networking as we all work together to increase immunization rates in our local community. So today, we're We're going to discuss a little bit about HPV disease and the vaccine, its safety and efficacy, discuss some of the reasons for vaccine hesitancy and some strategies we might work on together to improve immunization rates in our community. So as you're all familiar with, the Advisory Committee on Immunization Practices, which is part of the CDC, along with input from the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Obstetricians and Gynecologists, revises and updates their immunization recommendations each year for the vaccinations for both children and adults. And so I'm going to just show you 2023's charts quickly and where HPV fits into that schedule. There haven't been a lot of changes from the last few years related to HPV. So this is the table for recommended child and adolescent immunizations for kids 18 years of age and younger. And you can see I've circled HPV vaccines. One thing to note related to HPV is the box, or the two boxes between the recommended age of 11 down to 9 years of age. And so there's been a push by some people to try to move the age of immunization for HPV more regularly down to 9 years of age. I think in our practice, that's what we've been doing for several years now. And I think it does a few things. It helps alleviate the idea that maybe HPV is going to increase sexual activity among the children that are being vaccinated, even though I'll show you later on that that's been well disproved, but it takes it off the table in terms of discussion when you're talking about a 9-year-old with some of the parents. I think more importantly, though, it helps improve our rates of series completion because we have an extra opportunity when the kids come in for their required doses of Tdap and Menactra to give them what would then be a second dose of HPV, even if they've been a year or two away from the practice. And so that's kind of one of the highlights of this part of the table. And so HPV is recommended to be given routinely at 11 to 12 years of age. You can start as young as 9. For kids under 15, so up through 14 years of age, it's a 2-dose series given 6 to 12 months apart. After 15 years of age and into adulthood, it's a 3-dose series given at the first dose, second dose 1 to 2 months later, and then the third dose 6 months after that, with a minimum interval of 5 months for that third dose. It's important to remember, as with most vaccinations, if the schedule is interrupted, you don't need to restart. You'll just pick up where you left off. So no matter how many years have gone by, the patient can receive that second dose. And then no additional doses are recommended whenever any approved vaccine has been used for any of the doses in the series. Some special situations we see, such as immunocompromised patients, including HIV infection, would make the schedule a little bit different in that we need to use a 3-dose series for those individuals, even if they're in that younger age group. And then pregnancy, history of sexual abuse or assault should trigger giving the dose at 9 years of age as early as possible. And pregnancy sometimes comes up as an indication. We don't test for pregnancy before the dose. It's recommended to wait until the pregnancy is over before giving the vaccine. But if the dose is inadvertently given to a pregnant person, no intervention is needed and no repeat immunizations are needed in that case. And this table summarizes those two things, the pregnancy indication and precaution, and then the special dosing for immunocompromised and including HIV-infected individuals. And then this is the table that's used for adults 19 years of age or older. So we know that this vaccine is approved for adults up through 45 years of age, and through age 26. It's a recommended vaccine for anyone who has never received it to give a 2-dose or a 3-dose series. So if they had their first dose before age 15 and never received a second dose, they can get that at any time up through age 26. If they started after, then it would be a completion of a 3-dose series. That older age group from 27 to 45 has that blue box on it, which means that it's based on shared decision-making with the patient. So you'd want to discuss the benefits of the vaccination and its effectiveness, especially since many of them may have been infected already, but it might protect them against strains that they haven't seen. And so it might be useful. So HIV, the HPV vaccine. First of all, HPV is more common than most people think, and it requires your passionate advocacy. Most adolescents will be exposed, and I'll show you how early that is in a slide or two. We also know that the HPV vaccine works very well at the recommended age, and in fact, the earlier the vaccination is given, the more effective the doses are, so much so that under age 15, 2 doses is enough to elicit very strong immunity that is lifelong. The HPV vaccine is very safe, and importantly for many of us practicing directly with patients, more parents want the vaccine than we believe. So although as clinicians, we often focus on the more difficult encounters we have with patients, maybe where a patient or a family is not interested in the vaccine or is refusing it. But it's important to remember that about 80% of parents value HPV vaccine and are willing and interested in giving it to their kids. And there are many evidence-based ways to recommend it that will increase the uptake of the vaccine in your patients and families in our communities, some of them as much as by 10-fold. And so we'll go through a few of those recommendations at the end of the talk. So briefly, what is HPV? It's a virus that infects the skin and mucosal surfaces of individuals. It's transmitted very easily, even through casual touching. And so it is the cause of not only some cancers that we'll talk about, but also warts on hands and feet, as well as genital warts. And there's different strains of the virus that cause these different conditions. So they're not all carcinogenic, but several of the strains of HPV are considered oncogenic and are classified as known carcinogens by the FDA. Most females and males worldwide will be infected with at least one type of mucosal HPV at some point in their lives. And so this just shows the different types. There's over 120 different types of HPV, and about 40 of them infect mucosal surfaces, which would include the genital areas. The others are called the cause of common warts on the hands and the feet. The 4 types listed here, 16 and 18, are highly oncogenic and are causes of cervical as well as oropharyngeal and anogenital cancers, as well as low-grade cervical dysplasias. Type 6 and 11 can cause genital warts, laryngeal papillomas in the throat, as well as low-grade cervical disease. And these 4 are included in the vaccine, along with a few other subtypes that are also associated with moderate and lower grade disease and precancerous lesions that could progress to cancer. So the HPV vaccine that's currently in use, the Gardasil 9, covers for these 4 plus another 5 subtypes of HPV. About 3 million Americans, actually more than that now, seek medical care for HPV each year. And the most recent data I could find was collected between 2015 and 2019, which showed that there's about 47,200 new HPV-associated cancers in the United States each year. And of that, about 33,700 are attributed to HPV. And it's, as you can see, in both women and men, 26,000 women, 21,000 among men. So it really affects the entire population. It currently causes as many deaths annually as measles did in the pre-vaccine era. This is the newest table I could find that's kind of that classic pyramid that shows the burden of disease. And at the bottom, oropharyngeal cancers, although we don't think they're not the first thing that come to many people's minds, cause a large number of cancers related to HPV, and mostly among men. Above that are your cervical cancers in women, and then the anal, vulval, penile, and vaginal cancers in men and women. So this is a table that shows the burden of disease here in New Jersey. We have about 1,180 cancer cases that are HPV associated in 2020, and that was about 10.5 cases per 100,000 people in our state. So you'll see, luckily, New Jersey is the lighter color. It's in that lower range for HPV-associated cancers compared to other regions of the country, but still a very important problem. This slide I keep in, and I updated the numbers a little bit for 2021 population. It shows the burden of disease if we had no vaccine at all. And this kind of shows us exactly what we're hoping to prevent. So of the 32 million, and this is just girls, in the United States under age 15 in 2021, if there were no vaccine, 207,000 of those girls would develop cervical cancer, and 66, almost 67,000 of them would die from their cervical cancer over the course of their lifetime if none of them were vaccinated. So this is what we're trying to prevent. And you can add to that the cases of oropharyngeal and other genital cancers to double or triple those numbers. So why do we vaccinate? Obviously, it's to prevent infection, which will then prevent the HPV-associated cancers. And importantly, because we don't have a reliable way to screen for many of our HPV-related cancers. And even cervical cancer. This next slide shows the number of women who are up to date with pap smears, meaning they had a pap smear within 3 years of their cancer diagnosis. And 28% of women who were diagnosed with cervical cancer had a normal pap smear within the 3 years prior to that diagnosis. So although pap smears are useful and will will decrease cervical cancer by about 80% in our population, it's not perfect. And so vaccinations, if we can get the coverage up, would decrease those rates of cancers. And I'm sure you're all familiar with this, but why do we want to protect boys from HPV? And it's because they do get cancer related to HPV infections. As you remember from that pyramid slide, oropharyngeal cancers are most common in men. And importantly, there's no screening test for oropharyngeal cancers, so they're often detected later. Genital warts are result from HPV infections, as well as anal and penile cancers, which we'd like to be able to prevent. It's important to note that about 80% of people will become infected with HPV at some point in their life. And while the most common route is sexual intercourse, HPV does live on the skin, and so other genital to genital contact that doesn't include intercourse can result in spread of the infections. Condoms can help avoid infection, but they don't stop the transmission completely because of the way the disease transmits. And we know that a lot of sexual experimentation happens early. So a third of 9th graders and 2/3 of 12th graders have had sexual intercourse by the time they're in those ages. And 24% of high school seniors have had sexual intercourse with 4 or more partners by the time they graduate high school. And so the idea is that if we want to prevent HPV transmission during these sexual encounters, we need to have these young people vaccinated well before they're exposed to the virus. It's also important to realize that HPV can be transmitted, and young people need to know this without, quote unquote, having sex. And so studies looking at the frequency of vaginal HPV among women who have had non-coital sexual behavior shows that it is possible HPV has been detected in women prior to their first vaginal sex in studies that have reported a range of percentages between 9 and 46%, depending on the study, but it's definitely nowhere near zero. And 70% of these women do report other sexual behaviors that can explain the genital transmission even before they've had their first sexual intercourse. This slide is an older one, but I like to keep it in here because it does show the rapid acquisition of HPV by males and females after their first sexual intercourse. And so this was a study done in college-age students who started college with no prior sexual activity, but who presented to the college health services for counseling and contraception information because they were planning to become sexually active. And you can see that the bottom, the x-axis shows the months since their first sexual intercourse. And then the y-axis is the cumulative incidence of HPV infection. So it goes from 20 to 40 to 60 to 80%. And so the yellow line shows the males within the first year, they're already up to about 40%. And by 2 years since first intercourse, 80% of them have acquired HPV. And the females similarly rise a little bit quicker and then stabilize at around 60%. So within the first year, there's a significant rate of transmission. This slide shows the teen sexual activity by age, which I gave you the numbers for earlier, but it shows it graphically, and I think it presents a pretty compelling picture. So you can see that, among the 9, 10, 11-year-olds, there's very little sexual activity. But once kids hit 13, 14, and 15, and up through their young adult years, the rate of sexual activity goes up very quickly. And so, again, you don't want to wait for the exposure before giving the vaccine. It's important to remember, too, that HPV may never go away. This is a small study, and there's still scientific debate of it in the community. But this recruited 700 women aged 35 to 60 who had new detection of HPV, and 13% of them that couldn't be attributed to new sexual partners. And in fact, 85% of these newly detected infections occurred during periods of abstinence or monogamy. The effect did increase with the number of lifetime partners, but it seems to be that these women were probably infected earlier in life. We think many of them when they were in their teens and 20s, and the virus stayed there and then activated or reactivated later on in life. So we really want to be able to prevent that initial infection so that the virus can't take hold. I showed you the picture earlier of the HPV virus, and the vaccine is made from a virus-like particle, which looks pretty much identical to the virus itself. And so it's a recombinant L1 capsid protein. This is not so important to most of us who are trying to work on public health, but it's important to note that I think it's interesting. The virus looks very much like the live virus, except it's non-infectious and non-oncogenic, and it induces a very strong immunity that seems to be durable lifelong. 3 things that are important for us to know and also to help our patients and families know is that this vaccine is safe, effective, and provides lifelong protection. And so the benefits of HPV vaccine outweigh the risks by a great deal. And studies have shown HPV vaccination has a similar safety profile to the meningococcal vaccine and the Tdap vaccine that most of our patients are already taking. We know that it works, and I'll show you some of the population impact studies that you can use with your patients to show that it works and works well. And studies are showing that the protection really is long lasting and doesn't show any waning effect. And so this study is a few decades old, and it was reported in 2013 based on data comparing the period 2003 to 2006 with 2007 to 2010 when the vaccine was introduced. And what it shows is that in the younger age group, that first set of bars where the vaccine was used among those individuals, the rate of HPV detection decreased about 56% within that age group. And whereas in the older age groups where they didn't receive the vaccine, the rates of HPV remained fairly constant between those two time periods. So it seems to be that the most logical conclusion is that these people, having been vaccinated in the younger age group, were given protection, and so the rate of infection was less among them than in the same population among older folks who weren't vaccinated. And that was a 56% decline. This slide shows just looking at the general population between the different time periods. So the top left shows cervical HPV infections among females 14 to 19 years of age, which showed a 71% decrease overall from the period 2003 to 2006 compared with 2011 to 2014 when the vaccine had been introduced. Also, cervical precancers went down by 59% between 2007 and 2014, and oral HPV infections among both males and females 18 to 33 years went down by 88% among unvaccinated individuals compared with vaccinated individuals, compared with the unvaccinated. So the vaccine seems to have a very good effect in our population for three of the major outcomes of HPV infection. In Australia, this is another study that's now 10 years old, but this was done looking at teenagers in Australia, young people under age 21, during the time when only females were being vaccinated, and looks at what happened when they achieved a 70% coverage rate among females in their population. And it shows that not only did the number of genital warts in that population go down, but there was also an effect among males who at that time were not being vaccinated. And so we can see that it decreased not only the acquisition of the virus among those vaccinated, but transmission of the virus in the population as a secondary effect. And in this same population in Australia at that time, there was no decrease in the rate of genital warts among older men and women over that same time period. So transmission continued among that group. So unfortunately, in spite of all the good evidence that we have that HPV is important and effective, the vaccine is underutilized. HPV vaccination rates have increased, but fairly slowly, leaving still a large number of people vulnerable to HPV infection and cancers. And our HPV vaccination rates still do lag behind rates for other vaccines that teens are receiving. We also know that HPV vaccination coverage rates can be very high given our current healthcare structure. And how do we know that? Because the same population has very good rates of getting the Tdap and the Menactra, the meningococcal vaccine, which can be given at the same time. So for each year that we stay at, this compares a 30% coverage versus an 80% coverage. Right now, we're about 50%. or 60% coverage. But for each year that we remain lower, you're going to have a number of people who are going to develop cervical infection and death from cervical cancer. And so, as I said, the rates are increasing slowly. This is from the website for Healthy People 2030, and it shows that the most recent data shows that about 58.5% of the population of young adults were vaccinated against HPV in 2021, compared with 48% in 2018. So between those 3 years, it did go up. The target is still 80%. And so we're moving in the right direction, but still a little slowly. This table you've probably seen before. It's an updated one that compares Tdap, meningococcal, and HPV vaccine. And you can see that meningococcal and Tdap vaccination went up pretty rapidly between 2006 and 2010, 2011, and have stabilized well above 80%. HPV has been climbing very slowly. And the different, the bottom numbers show having had at least one dose of HPV, and that middle line shows people who have completed the HPV series and are up to date with their vaccine. These next 3 slides break it down by sex, race, and ethnicity, as well as poverty level. And you can see that among males are still slightly lower compared with females are above, and the overall rate obviously is somewhere in between, and we're still somewhere around 50-some% overall. There are differences among the different racial and ethnic groups, and so Hispanics have a higher rate of HPV vaccination compared with non-Hispanic whites, and all races are intermediate. And then poverty has a small effect as well. This compares people who are living at greater than 200% of poverty versus people who are below the poverty level. And ironically, the people living below the poverty level are actually slightly better in terms of their vaccination rates. In New Jersey, our rate in, I believe this was 2021 as well, was 54.8%. And so we ranked 45th among the states. So New Jersey has a lot of work to do to catch up with the rest of the country. This looks at HPV immunization rates here in New Jersey and compares some different factors. So in our state, as nationally, people below the poverty level actually are doing a little better, 54% compared with 46% of people who are living above the poverty level. Hispanics have highest rates of coverage compared with Black, white, and other or multiple races. And then MSA refers to metropolitan statistical area. So when you're talking about the principal cities, the rates are a little higher than with smaller cities. And insurance, Medicaid recipients have slightly higher rates compared with other insured categories. This compares rates here in New Jersey with the United States as a whole, and the red line at the top is the target for HPV being up to date of 80%. These are having a single dose of HPV vaccine versus the broken lines are where the series are up to date. So the up to date rates are around 55 to 60%. And when I spoke earlier about trying to reach coverage and what's possible with our current system, this slide is interesting. It compares HPV infection, which is the third set of bars, with 3 other vaccines. So the first set of bars is the meningococcal vaccine. The red dots are the Healthy People 2020 target, so a target of 80%. So the meningococcal vaccine, both in New Jersey and the United States as a whole, have surpassed the 2020 target, as has Tdap vaccine. But you can see that HPV vaccine is below the Healthy People 2020 target by quite a bit. And in New Jersey, we're lagging behind. Ours is the blue bar compared with the United States as a whole, which is the green bar. So it just kind of summarizes all of what I've said in one nice slide. Add to that now COVID-19. So this is from the WHO. It was on their website just a couple of days ago when I pulled this up. COVID-19 pandemic has fueled the largest continued backslide in overall vaccinations in 3 decades. So a lot of people missed out on vaccines in general. And I think we saw that here in New Jersey, just looking at our NJIIS data as well. This is an article from 2021 when COVID was just getting started, and it showed the impact of reduced immunization to HPV coverage rates due to the COVID-19 epidemic here in the United States. And a couple of others that were published very recently. So this is the American Journal of Managed Care had a piece looking at gaps remaining in HPV coverage for children due to the COVID-19 pandemic. Infectious Disease Advisors had an article about HPV vaccination, which showed that the vaccine rates really went down most among the youngest eligible age group during the COVID-19 pandemic. So these are the young 11 to 12-year-olds were actually the most affected by the pandemic in terms of reception of their HPV vaccine. And that's the age group, as we mentioned earlier, that is most likely to benefit from the vaccine the most. And so why do people refuse the vaccine, or why don't they get the vaccine? Partly it is refusal. So we do have some parents and some patients who refuse to get the vaccine, but there are other factors as well. Many times or often it's providers who fail to offer or who delay offering the vaccine. And I'll show you a couple of slides about that in a minute. And then in some populations, the problem is really access. They would like to get the vaccine if they could, but they don't have access that's easy and able to be obtained. So what we need to remember is that every time an adolescent is seen for healthcare, that's really an opportunity to immunize them. And each adolescent visit to a provider may be your last chance to immunize them. 30% of our adolescents never present for preventive care, and only 1 in 15 adolescent visits are for some type of preventive care when vaccines are traditionally given. So that means 14 out of 15 times the adolescent is going to be there for something else, but may not have a contraindication to receiving a vaccine, and it would be a good opportunity for you to encourage that vaccination and to offer it. We know that preventive visits decline steadily after age 13, and that earlier adolescents in that 11 to 14-year-old age range were 3 times more likely to have visits for preventive care compared to late adolescents. And so we really want to get across to all of our providers that sick and well visits are equally appropriate for providing immunizations, and we should be offering it every time we have an eligible patient that doesn't have a contraindication. One of the things we know is that sometimes it is our fault as providers. And one of the things that tends to go into that is that we often will overestimate, especially parents' concerns and in certain populations about the vaccine. And when we overestimate parental concern, and anticipate that a parent may not want the vaccine, then we might be less likely to offer it for fear that it would be rejected. And we don't want to cause any friction with a family that we think might not value or view the vaccine favorably. The truth is that 55 to 90%, more like 80% of parents value the vaccine and will follow provider recommendations. Most parents do believe that their sons and daughters are at risk of an STD at some point in their life. And even though they may not want to think about it at the moment, they would acknowledge that that is a real possibility for their son or daughter. And there's differences. So this compares the different vaccines, and it looks at a parent's value of that vaccine on a scale of 0 to 10 versus the provider's estimate of how they think the parent would value that vaccine. And so we have pretty good agreement between what a provider thinks a parent would want and what a parent says they would want for meningitis, hepatitis, pertussis vaccines, where we all agree that parents would value that well over 9 out of 10 times. The flu, we're not talking about today, but it's another one where the provider tends to think families will not value the vaccine more than the actual family's value that they place on it. And HPV is the worst. Look at that. 5.2 is what a provider thinks on a scale of 0 to 10 a parent would place as a value of an HPV vaccine, whereas the parents are telling you they value it equally among other vaccines, 9 out of 10. For those parents who do opt to either not vaccinate or delay vaccinating their children, what is the most likely reason? Some of them believe their kids are not sexually active yet, and so they don't need the vaccine. They're worried about safety. But the most common reason they don't vaccinate their children is either they're not needed or it's not recommended by their provider, especially among boys. So almost 25% of parents of boys said that they didn't get their son vaccinated because it wasn't recommended by the provider when they went to the visit. So one of the things related to that slide, the first thing on the slide there about being sexually active, is some parents' concerns that HPV vaccination might encourage or facilitate their child to become sexually active. In other words, give them some kind of permission for that. 3 large studies, including over 200,000 girls and young women, firmly disproved that belief. HPV vaccination was not found to be associated with being sexually active. Number of sexual partners looking for or receiving counseling for contraception or testing or diagnosis of sexually transmitted infections. So we can confidently reassure parents who raise that as a concern that getting the vaccine, even if it's for a sexually transmitted infection, will not change a child's sexual activity, desire for sexual activity, or participation in it. And so how can we accelerate HPV vaccine uptake? So this is some older slides, but I think the concepts are still important. This was from the President's Cancer Panel 10 years ago, and it showed, it really looked at 3 areas. So reducing missed clinical opportunities, which I mentioned, utilizing sick as well as well visits for immunizations, increasing the acceptance of vaccine, especially HPV vaccine, among parents, caregivers, and adolescents by giving them good information, by dispelling myths, and by motivating them to understand that it is something that is in their best interest. And then also increasing access to HPV vaccination among the age groups where it's going to have the most important effect. And so objective 1.2 was that providers should strongly encourage HPV vaccination among all age-eligible children whenever any other vaccine is administered. Again, top 5 reasons for not vaccinating. This is the daughters. For parents, not recommended, 13%. So we really need to be recommending the vaccine. And then these other things like safety, necessity, as well as lack of knowledge are all things that we can discuss in our offices with families when they come in to see us. It's important to know that the clinician's recommendation really is important. So the top shows whether a provider recommended against, didn't talk about it, or recommended strongly that a child receive the vaccine. And then going down the column, the child got, will not get, was unsure, or didn't know. And you can see that the purple, where they're 36.4, 33.7%, are the children who got the vaccine and were recommended by the provider strongly to get the vaccine. The one to the right, 45%, shows that when the vaccine was not discussed at all, about 45% of parents said they wouldn't get the vaccine. So we need to talk about it. Among those who did get information about the vaccine, 21% said they still wouldn't get it. The other thing is, it's important not to wait to give the vaccine. We showed that the vaccine is most needed before a patient becomes sexually active, and most effective the younger it is that it's given. And yet there are providers who delay making a strong recommendation for the vaccine until beyond the actual recommendation age. So 80% of among 13 to 15-year-old patients, 80% of providers would strongly recommend it. And among 16 to 18-year-old patients, 85% of doctors would strongly recommend it. Whereas among the 11 to 12-year-olds, only about 50%. Now, this was in 2011, so hopefully these numbers are better by now. But there is a proportion of providers who don't recommend it or don't recommend it strongly among the younger patients. And then the third objective that I'm going to highlight here relates to structural things that healthcare organizations, as well as physician practices, can do to improve vaccination rates, which include things like using the electronic health record and the immunization registries to help find patients who need vaccines and do outreach, as well as to avoid missed opportunities by checking all patients to see when they need a vaccine. So there are some evidence-based strategies that will improve immunization rates. Reminder recall, again, using the registry and EMR prompts to find patients who need the vaccine and bring it to the provider as well as the patient and family's attention. Use of things like standing orders, so that if another practitioner in the office, like a nurse, is empowered and enabled to look up whether a patient needs a vaccine and utilize a standing order to give that vaccine without needing to actually have the provider speak about it or do it, can increase rates, as well as providing feedback to practices in our region through the registry, through our coalitions and our outreach, so that practices and individual providers know what their coverage levels are, what work needs to be done within their own practice to improve their rates. Again, a real important resource we have, and it's housed within the partnership, is the immunization information system. And then lastly, the CDC and others should develop, test, and collaborate with all of us to implement strategies that will direct it at parents, caregivers, and adolescents, so that they will seek out the vaccine when they go to their doctors and to their providers' offices. And so there are some of these brochures. These have been around for a little while. I think these are still relevant, but we do want to make sure that the materials we use in our offices are appealing, that they're culturally appropriate for the families that we're working with in our particular practice, that they use language and pictures that are going to be motivating to the families that we work with. And so our families need, and the children need to see themselves in these images and in these statements so that they can relate to them on a personal level and really want to seek out the vaccine for themselves and for their families. So lastly, I have just a couple more slides. What can we all do to improve immunization rates now that hopefully we're reconvinced of the importance and the efficacy and the safety of these vaccines? And so there's work to be done on many levels. The departments of health, both at the state and the local levels, are important places where we can work on outreach, both to the community as well as to providers in our region to increase rates, use of state registries, working with our schools, so school nurses, as well as school-based programs to raise awareness for vaccines, and in some cases to actually give vaccines in school-based clinics would be a good way to increase coverage. One of the things I didn't mention, but I think one of the biggest differences in uptake when you look at Tdap and pneumococcal vaccine versus HPV is that the first two are required for school 6th grade entry. HPV is not. And so advocating for including HPV as a required vaccine for school entry would bring those rates up much more quickly. And some estimates are that it would increase the rate of uptake by as much as 20 years faster if they were made required vaccines. Other community organizations, such as many that you all represent, can provide education, outreach to both providers and to the public, and then developing public health materials and education that's appropriate and motivating. And so we can partner with our professional organizations as physicians, the AAP and the AFP, other professional organizations like public health societies, cancer coalitions we have on our call, other alliances and organizations, the Cancer Society, and of course, EMIC and the partnership for materials, as well as for support among ourselves to continue the fight and to keep up the work. And so the last slide was something that came out just in our most recent issue of our pediatrics journal from May, that was a meta-analysis of 32 studies that looked at provider-based HPV vaccine promotion interventions. And it showed that in this meta-analysis, regardless of the kind of intervention that they used, they found significant improvements in both HPV initiation, increases of 3.7%, as well as patients receiving the next dose, which increased by 9.4% among the 32 studies that they looked at and included in the analysis. And these interventions were effective in improving immunization rates, regardless of what type of intervention it was. And they couldn't find any one that was more effective than another. So anything that we do to target HPV immunization and try to increase rates is going to have an effect. What we want to try to develop are interventions that are continuous. That is, we need to keep plugging away at this provider by provider, patient by patient, and try to notch up little by little every time we have the opportunity, and create interventions that are sustainable. In other words, things that are practical, that are workable, that don't increase the burden on either the providers or the practices, and that don't increase the cost, because only then are we going to have things that people are going to continue to do that are can be able to implement in the long run. And so I'm going to leave you there. Hopefully this will motivate you all to recommit to the fight against HPV and increasing HPV rates among our patients. And I look forward to continuing to work with you in the year and years ahead. Thank you.
Zachary, you have a question?
Yeah, Dr. Schwab, great presentation. I noticed you'd used some data from my data briefs that I had published. I just wanted to plug, I have a HPV specific data brief that's going to be that's revised and should be released this month. So if anyone is signed up for NJ Links messages, they will receive it, and it'll be also posted to our website.
Excellent. Thank you. Does anyone have any questions or comments or any items you'd like to share about your work with HPV in the community or in your organizations while we're on the topic?
Dr. Schwab, I know that I'm going to be presenting in a moment or so, but I did have a question for you in terms of vaccination, right? So if a person has received the 4-valent vaccine, probably, 15, 20 years ago, would it be beneficial for them to get the 9-valent vaccine now that that's what we administer in the United States?
Yeah, that's a good question. And I've asked that myself for my own family and for patients. The official recommendation is no, it's not necessary. If you've completed a series with an approved vaccine, you don't need another vaccine. And the 4-valent does include the most important oncogenic subtypes
Okay.
that are in the same ones that are in the 9-valent plus a few others.
Thank you. And a follow-up question to that is, I personally go into communities and I speak to a lot of parents, and there are some folks that come from underdeveloped countries and wonder they don't have vaccine records. They don't have access to what they've been vaccinated for. They don't know. And I did receive a question as to if they are unaware that they've been vaccinated, could they, or would it be beneficial for them to receive the HPV vaccine, even if they are unsure whether they received it or not? So it could be a potential possibility that they did receive it when they were younger, but they just aren't sure.
Yeah, so that comes out. I see that a lot myself in the practice. So if there's no record available and they're not sure, then we can revaccinate them as if they had never received the vaccine, and it shouldn't cause them any problem.
Okay, thank you.
Dr. Schwab, there's a question in the chat as well from Katie Stewart. Can you speak to the Costa Rica and US study looking at the efficacy of 1 dose of HPV vaccine?
So no, I can't. I'm sorry. Can you, maybe Katie, can you tell us a little bit about that? Or
Hi, Dr. Schwab. Thank you for this presentation. It was great. I just recently, as in my reading, I just ran across some mention of this Costa Rican study looking at specifically the efficacy of 1 dose, and that they were continuing to study it and saying that if it turned out to be efficacious, then it could really improve our HPV vaccine rates. So I was just curious.
yeah, so I think if anybody has any other comments, but I think in general, that's kind of what happened with when we went from the 3-dose series for everyone down to a 2-dose series. As new information comes up, sometimes these schedules are adjusted. It looked like with HPV, it turned out that when, especially in the younger patients, 2 doses were enough, and we could save resources as well as increase compliance in our younger patients by going down to a 2-dose series. And if a single dose could be proven to be as effective, then that certainly would be beneficial in getting knowing that we're compliant and knowing that we've had a good effect on a larger number of patients. So I'll be interested to follow. Zachary put in the chat, oh, the link to the New Jersey Immunization Conference next week. Yeah, so we're looking forward to that. And if anybody isn't aware of it, there's the link there to register as well. Thank you. Michael, I see you're talking, but I don't hear anything. No. Maybe you can type your comment in because you're unmuted, but you're not sounding.
Testing.
Yeah, now we can hear you.
Okay, you got me?
Yes.
Okay. Just got this new computer and having technical glitches. Anyway, great to meet everyone. I'm kind of new to New Jersey. And so this is good timing for the Cancer Society. As you probably know, HPV vaccination is a major priority for us. And we've been focusing on it for several years now. And one of the main messages that CDC and ACS has been trying to get across to providers is the importance of really framing the discussion with parents around, you know, the HPV vaccination being about cancer prevention and get it out of, you know, their minds as this is really about preventing a sexually transmitted infection. So that's definitely something we need to really work on with providers, make sure they're up to date with that kind of messaging. The other thing, I was really glad that you mentioned that your practice is starting at age 9 with the vaccinations, and that's something. Well, we're seeing that campaign across the country really being led by American Cancer Society and the National HPV Vaccination Roundtable and AAP actually. And one of the things that, if I can just add to your excellent data set that you shared, some of the recent long-term outcome data is really showing the increased impact of having the HPV vaccine completed by age 13. And so a lot of the data being shared was from NIS-Teen, which unfortunately starts at 13, and it's 13 to 15 is what's being shared, or 13 to 17. And what we really need in New Jersey is to understand who's receiving it by 13, because it really matters. We're seeing, like with cervical cancer, risk reduction of 90% if it's received by 13 versus dropping off to 50% at 14 to 16 and going down from there. So that's really critical. So I guess a couple of questions. One question is actually for SAC at the health department to see if there are any updates to the change in regulation for vaccination reporting by providers for the New Jersey IIS. We should be keeping our eyes peeled for that comment period so we can all weigh in on that and support increasing that to 18 so we have good HPV vaccination data for New Jersey.
Yeah, I'm actually going to
not to put you on the spot there, Zach.
That's okay. I'm going to kick that question off to Jenny to give the update on what's going on with the 18 age requirement.
Not hearing you.
Hi, Michael. Can you hear?
Having mic issues as well.
Michael, can you hear me? Hello?
We can hear you. I don't know if he can.
Okay. Just you can hear me, right, Dr. Schwab?
Yes.
So the immunization regulations, for those that are not aware, the department put out like a pre-proposal, if you want to call it that. We're currently stakeholdering, looking for feedback to our proposal before we actually put it through public comment. And so one of the proposals for IAS was to increase the minimum age. Right now, it's the IAS is currently, providers are currently required to enter immunization data for children under 7 years of age, so 6 years of age and under, into the registry within 30 days of administration. However, this is a lifespan registry, and we're looking to hopefully increase that age from 0 through 6 to 0 to 18, and eventually at some point, it's wishful thinking, but at some point maybe the all of the residents in New Jersey, but based on some of the feedback that we received, we'll have to see how that all plays out. I mean, it is all, we are following all HIPAA guidelines, and it is also a voluntary, it is voluntary to include, if you're 7 and older, it wouldn't be an opt. I always mess this up. It would be an opt-in as opposed to an opt-out, because currently anybody under 7 years of age would be automatically entered into the registry unless you file that you want to opt out. But for 7 and older, it would be an opt-in. And so hopefully that may help those folks who are reluctant to have their information on the registry. But we will be eventually going through public comment once we review these review the feedback from the pre-proposal, and then we'll push once we're ready for the next step, then we'll push that through the public comment period. Hopefully I answered the question. Thank you. Yeah.
Thank you. Thank you,
You're
Jenny.
welcome. Sure.
I have a feeling you mean it would be an opt-out system, because that's what most states have. The default would be it would go into the system, and but you can always opt out.
So we did that for we only did that opt out for COVID. I mean, for COVID, we had to automatically enter everybody in, because that is something that, because the federal government was providing free vaccines, we needed to capture that information. And so that was a requirement. But for children 7 and under 7, I keep saying 7 and under, but under 7, so 6 years of age and under, it is an opt-out registry where you're automatically entered in unless you opt out. And so I'm not sure if the same will hold true. Currently, 7 and older it's not the same for 7 and older. You need to provide permission that you want to be opted into IAS. So it may be a little bit different, but we'll see. We'll see what comes out of all of this.
Thank you.
Mm-hmm.
Well, I think it's almost 3:15, so we do have another brief presentation before we end the meeting today. So I think we'll move on, and we'll see if there's more questions after the next presentation as well. So I'd like to introduce Ureni Syme, the Public Health Program Coordinator for our Partnership for Maternal and Child Health of Northern New Jersey. Ureni works on our HPV and cancer prevention initiative, and we have been implementing this for the last 5 years. So Ureni is going to share some of the information that she has found through this program. And I forgot to mention before I introduce Ureni, thank you so much, Dr. Schwab, for that presentation. It was really informative, and I definitely felt more motivated to continue the fight for getting the HPV vaccine word out there. So thank you. Ureni, I'll turn it over to you.
Thanks, Emily. And thanks again, Dr. Schwab. So yeah, I'm going to try to be as brief as possible, because I know that the meeting is soon over. However, I just want to share a little bit about the HPV and cancer prevention initiative that the partnership that we work on, just to get HPV education out there. So the goal is that by October 31st, 2023, we would like to increase We are working to increase knowledge and awareness of HPV-related cancers and prevention for 600 individuals across the state of New Jersey, and we're in our 5th year of this program. And so our target population include healthcare providers, especially OBGYNs and pediatric providers as well, middle and high school students, and community members and parents. And so through continued activities, we educate staff and patients at dental and pediatric clinics in the state of New Jersey on HPV prevention. We partner with these schools to provide adolescent and parent education on the HPV vaccine. And then we also partner with local health departments and community-based organizations to host health fairs, panel, webinar presentation, and workshops. And last but not least, evaluating the impact of this education and knowledge of HPV, awareness of HPV vaccine recommendations, and HPV immunization rates. So, so far in quarters 1 of 2 of this grant year, we've reached a total of 867 individuals, with the most numbers coming from our student population, then following with our parent and community members, and then following that, our healthcare professionals. And we've also hosted 4 social media events where we engaged over 90 viewers. This is just quarters 1 and 2 of this grant year. So definitely in quarter 3, which is currently happening, we have reached at least over 100 more. So that's good news. Some notable events that we've had in terms of reaching healthcare providers have been these 2, as you can see on the screen. One of them happened this past January in collaboration with Dr. Gareth Summers, where on behalf of Cervical Cancer Awareness Month, Dr. Gareth Summers and I provided a remote presentation done via GoToWebinar on HPV and cervical cancer. And continuing education credits were offered through this presentation. And then we had another presentation in November of 2022, which was a faculty affairs presentation where Dr. Manaz Fatazadeh, which she's actually with us right now. So hi, Dr. Fatazadeh. I hope you're well. We collaborated and we provided also a remote presentation to the Rutgers Dental School to provide information on HPV and oropharyngeal cancer. So yeah, these were the 2 most notable, but we do more presentations such as this one to different healthcare providers in Jersey. And, you know, we physically go to these clinics if they would have us. And we also do more remote presentations if they prefer that as well. So this is how we reach our healthcare providers. And we also have Team Maureen. So for those of you who haven't heard, the Maureen E. Russo nonprofit organization was founded as a promise and in memory of Maureen E. Russo, who passed away from cervical cancer at 37. So their mission is to end cervical cancer by educating HPV cancer connection and the importance of prevention and early detection. So the partnership has been working in collaboration with Team Maureen since 2019. And we have toolkits, we have pamphlets, flyers, posters in our offices that we share to dental providers, and we mail to different dental clinics in Jersey. So something that I would also want to share here is that we've collaborated very closely with Dr. Sam Joaquim, who works in Zufall Health Center. I know many of you have heard of him, and this is just a notable piece of information, some research that he shared. He publicized this article here that discusses the cases of oropharyngeal cancer linked to HPV, and sharing how to, you know, his knowledge, they've accomplished a first of its kind project through Project AIM, and it's a great read and very informative. So if anyone is interested, please go ahead and look that one up. And yeah, so moving forward, just for the sake of time, we also have our own project that we're collaborating with NJIAS. So this is a fundamental training to boost HPV vaccination rates. One of my colleagues will be sharing this flyer in the chat if anyone is interested. But the point of this project is it's a virtual webinar that is designed to provide healthcare providers with the tools and knowledge to effectively utilize NJIAS to increase HPV vaccination rates in pediatric settings. So we are reaching pediatric clinics in Jersey, and we're hoping to collaborate with them so that they, you know, can learn about the importance of the vaccine. They can learn about the current and New Jersey vaccination rates. We can discuss effective strategies to improve HPV vaccine rates. And of course, with the NJIS fundamentals training, they'll learn how to utilize NJIS to review inventory, add patients, run reports, and add HPV immunizations to the patient record. So this is something that is ongoing. And if anyone is interested, they can, download the flyer that's from the chat room or reach out to me. Now, a little bit about some community outreach. These are the red dots here are where we've reached in Jersey in terms of health fairs, in terms of middle and high school education, and in terms of other community-based outreach. So we've reached about 6 counties at the moment. It's great. We're looking to continue to expand. Now moving forward to student outreach. So we go to different, as mentioned, middle schools and high schools, and we provide classroom education where we do pre and post survey. And on the screen, you can see the pre-survey that looks almost identical to the post. And we ask some questions about, as you can see here, which of the following is the most common STI? What is the most common HPV-related cancer in men and women? And how effective is the vaccine? And we see how much they've learned from the beginning to the end of the presentation. And as you can see here, this is findings from 359 student surveys. So there's definitely a huge percentage change in their knowledge from before receiving HPV education to after. They have pretty low scores in the pre-test, and once they receive the education and take the post-test, they do much better, and they gain a lot of knowledge from this presentation. So this is just some data from these student surveys. These are done anonymously, so we just try to gather unidentified. We just look for an unidentifier, or just anonymously have them fill out the survey so that we don't, they can provide as much honest feedback as they can. And I know that Dr. Schwab touched on this, so I'm just gonna skip over this just because he went into detail about these two graphs. But I just want to quickly mention again that while that COVID did play a big role in HPV vaccination rates, and because we know that the healthy people goal is 80%, and in 2021 it was at 54.8, and in 2020 it was actually higher. It was at 59.7. So while we have been steadily increasing from 2018 to now, we unfortunately did see a big drop because of COVID and the fact that we were telling folks to stay home, and kids were studying from home, so they weren't needing to go get their vaccines at the doctor, and they were getting remote education. So we need to, continue to push forward to recommend the vaccine. Some frequently asked questions and personal insights from my experience in the field and talking to many parents is that there continues to be misinformation that still persists from many years ago, such as the belief that the vaccine is only for girls and that only girls can get HPV. Also, the belief that children do not need to vaccinate until after they are sexually active, or parents are waiting for them to become older and independent for them to personally decide whether they want to get the vaccine. There's a belief that still lingers that HPV is only transmissible through sexual intercourse, and that if protection is used, they can't get HPV, and also that HPV is rare. And another, very big problem is that parents just in general are still hesitant to vaccinate, not specifically with HPV, but just in generally because of its side effects and beliefs that it may cause problems and other side effects to their children. So these are just some personal insights from from when we speak to parents and teens and, community members out there. So that pretty much sums up my presentation. But if you are an educator, a healthcare provider, or an affiliate of an organization that does provide services or education to communities through workshops, through health fairs, please reach out to us, and that way we can collaborate and continue to provide HPV education to healthcare staff, students, and the community at large. And that ends my presentation. So thank you. And if you guys have any questions, please feel free to unmute and ask in the chat.
Thank you so much, Ureni. Are there any questions for Ureni before we move on? I do want to say if there's any pediatric providers on the call, or if you're working with pediatric providers, Ureni is actively doing outreach to support offices and clinics to increase their HPV vaccine rate. So I just want to really emphasize that, if you have any connections or, contacts to share with Ureni, she's able to help walk them through with our NGIS team how to use NGIS to evaluate their HPV vaccine coverage rates, how to implement reminder recall, to get the patients, to identify the patients who are under vaccinated, and to get them back into the office. And this is a great time of year to do this because, as summer comes up, and you, like Dr. Schwab mentioned, you may have adolescents coming in for other reasons, camp or sports physicals and things like that. And so this is a really good time to identify your patients who are not up to date with their vaccines and to catch them up during other visits. So Ureni's here to help. Okay. So I'm going to briefly share just a quick update about the coalition before we end. Let's see. Okay, share. Okay. So for those of you that joined a little bit later, my name is Emily Haynes. I'm Director of Public Health Initiatives at the partnership, and I oversee our immunization initiatives. So at the quarterly EMIC meetings, we just give a brief update of our working groups and what we've been working on, as well as just an update on the status of our immunization programs. So I wanted to share that we did announce the winners of our annual Protect Me with 3+ contest. This is a collaboration that the partnership works on with the New Jersey Department of Health Vaccine Preventable Disease Program. And you can see this, these are our student winners. We had winners from all over New Jersey. And these are some of the winning posters. So our first place poster from Priya Patel. She was a 10th grader from Triton Regional High School in Runnymede. And our first place middle school poster, Marquis Jeter, is a fifth grader from Franklin Elementary School in Rahway. We also had our high school winners as well for their videos. So we were really happy to have great attendance and turnout for the ceremony and get to interact with the students and their families to celebrate their creative accomplishments. And we'll use these for public service announcements throughout the state. And we do use the student videos as well for promotional videos in doctor's offices and the DMV. Last year, we used some of our flu videos to promote vaccination. And the Step Up Vax Up campaign, which is the campus health awareness campaign through the partnership, also announced their second year winners. So first place went to Kira Benson from Felician University. Second place went to Amy Valencia at Farley Dickinson University, and third place went to Anna Yanisco from Rutgers University. So their videos are available on the Step Up Vax Up website, as well as the social media. They're great tools to share, information about getting college students vaccinated, specifically for COVID-19 vaccine. And for next year, the Step Up Vax Up campaign will also include other recommended vaccinations for young adults as well, in addition to COVID-19. So it's a great opportunity to help get the college student population up to date on vaccinations. For the EMIC Community Education Working Group, Ureni actually hosted a workshop in collaboration with Atlantic Health on May 23rd. We also presented an educational webinar event, Improving the Vaccination Experience for Accessible Vaccination for Neurodiverse People at Any Age. And that was a really successful educational event. We had participation from many of our EMIC partners. And then as a result, since they were trained on how to improve the accessible vaccine clinics, we were able to provide resources to those clinics to implement those strategies to improve the vaccination experience for especially children with autism. And some of our local health department partners through the coalition were really excited to receive the kits and actually told me that they may end up using them as well for lead testing with those families, because really any procedure, it helps to reduce the anxiety for the children and really helps to, improve the overall experience with the health department. So we're excited to see how that is implemented this summer and hope to expand that initiative in the fall for flu clinics. Jasmine Anderson is on the call, and she is conducting workshops throughout the summer as part of our Andre's Armor book initiative. So she is using the book to help promote vaccination for parents with children. It's really targeted for 0 to 8, but anyone with a child under the age of 12 is able to participate in the workshops. And her contact information is here if you're interested in learning more about that or setting up a workshop. Just a quick update, we are currently at 150 members of the coalition, which is great. We've had a real increase this year. And we also developed the EMIC LinkedIn learning page. So if you haven't already signed up to be a member of that, please go on to LinkedIn and we can connect you with the group. It is a closed group for just EMIC members, but you can post resources on there, ask questions. It's really an opportunity for you to network in between our meetings. The partnership also created a subcommittee of our regional education committee, which is focusing on pediatric topics. And we had our first meeting this quarter, and we did discuss the need for potential RSV vaccine education as the RSV vaccines are, potentially coming out this year for pediatric population. And there was also a lot of interest from the pediatric providers around respiratory disease prevention and management. So, working with flu, COVID, RSV prevention for their patient populations, especially the children with comorbidities of asthma and obesity. And Leanne is on the call for NJIS reminder recall outreach. If you have questions around NJIS, please do not hesitate to contact Leanne and her team. We're also currently planning flu clinics for the fall, and we are looking for partner organizations in Essex County. So if you're working in an office, clinic, or hospital in Essex County, please let us know if you would be interested in partnering with us to host a flu clinic. We are working with the New Jersey American Academy of Pediatrics on that as well. So we'd like to, really make an accessible event for the community to come get their flu shots in the fall. And we would like to partner. And lastly, I'm going to put it in the chat as well, but next week we also have the partnership's annual meeting, and Dr. Monica Gandhi is going to join us to present about her new book, Endemic, a Post-Pandemic Playbook. So if you are interested, you can register for that free meeting. It's in person at Montclair State from 10 to 12. And that is all of my updates. So I will stop sharing. I know we're 5 minutes over, but if there's any questions or comments from the members, we did have the minutes approved. So thank you, Michael, for doing that. And I see some updates too in the chat from Brittany about Step Up Backs Up.
Emily, this is Jenny. Can you hear me?
Yes.
Hi, really quick. Are we thinking about having in-person meetings ever again, or this is all virtual?
So we would like to, we actually tried to have this June meeting in person today, but there wasn't a lot of registration for in person. So if that is of interest, we would like to start having EMIC meetings in person again. But we just want to make sure that it's, makes sense for us to have it in person. If there's only going to be, 3 people there,
Right.
it doesn't make sense to, so.
So will you be sending out a survey or something just to assess everyone's interest?
Sure, that's a great idea, Jenny. I'll send a survey out.
That'd be great. Thank you. I appreciate the networking that happens at these meetings, that may not necessarily happen virtually. So
Sure.
thank you. Great meeting, everyone. Thanks.
Thanks, Jenny. Any other questions before I turn it back over to Dr. Schwab?
Jenny, this is Iris from Horizon. I just wanted to remind the group, any questions or inquiries from the community regarding the recertification and renewal process as it pertains to their Medicaid coverage. Please feel free to connect. I'm happy to provide you information, some flyers, and promoting the renewal process so folks don't lose their coverage, as it directly impacts health outcomes and the ability to access care. So please remind families to look out for those mailers. They're going to be robocalls. There's different means, text messages, reminding folks that they need to recertify their eligibility with NJ Family Care. So please, let's try to pay attention, and if folks need information, I'm happy to share those resources.
Right. Thank you, Iris. Dr. Schwab, I'll turn it back over to you to close the meeting.
Okay, yeah, thank you. Thank you, Emily. And thanks, Rennie, also for that great presentation. And Emily, for summarizing all the good work that the partnerships do, and for all of you who participated. We appreciate your membership and your contributions to our efforts to improve immunizations. It's a warm welcome to all the new members as well. And hopefully we'll see some of you next week. I know the immunization conference and our annual meeting coincide, so pick one, but I'm sure we'll see most of you at one or the other. And looking forward to seeing you all next quarter. Again, if anybody's interested in being more active, you can join one of the working groups that Emily is coordinating. I think you coordinate both of them, right? Yeah. And it's a way to get involved specifically with EMIC. But anything that you're doing in the community, please send through and we'll post it both in our newsletter that goes out by email as well as on the different social media. And looking forward to seeing everybody again in the fall. Have a great summer. And
where is the immunization conference?
it's online, I think. Zachary, do you have more?
It's virtual,
it is,
yes.
Oh, virtual?
Hey, Dr. Wenger, it's so nice to hear your voice. Yes, it is a virtual conference this year.
And this is just immunization general. This is not the adult one.
No, this is not the adult immunization conference, which will be in the fall. I'll post the link for the registration for the Rutgers flyer that announced the NJIC conference.
I posted it in the chat, Jenny.
Oh, thanks, Zachary.
But the chat ends quickly with the end of this meeting. Is there anywhere?
Sure.
Yeah, Dr. Werner, I can make sure you get a copy of it. I'm going to send an EMIC email out tomorrow as well. So in the registration.
Oh, send one to me too. Okay, thank you. Terrific. You guys do great work.
Thank you. Thanks, Peter.
Really. It's good to see everybody.
Okay, thanks. So with that,
Even virtually.
Yeah, even virtually, even just the names on the screen.
Right.
But yeah, thank you all for your attendance and for your participation, for making this a lively meeting. I think it was a very good one. So I appreciate it. And again, enjoy the summer and we'll be in touch. Take
Thank
care.
you. Bye-bye.
Hi.